Hello everyone, I am Etable Hana Vivienne and I'll be reporting about the definition of terms in thoracentesis. Thoracentesis. It is a procedure in which a needle is inserted into the pleural space between the lungs and the chest wall. A thin layer of pleural fluid normally remains in the pleural space. An accumulation of pleural fluid may occur with some disorders. That is why a needle biopsy of the pleura may be performed for diagnostic or therapeutic purposes. Aspiration indicates a purposeful intake of breath, an accidental inhalation of material, or a medical procedure for obtaining a tissue sample. Centesis. It is a surgical puncture of a membrane or body cavity to remove fluid. Pleural cavity. The pleural cavity is a fluid-filled space that surrounds the lungs. It is found in the thorax, separating the lungs from its surrounding structures such as the thoracic cage, intercostal spaces, the mediastinum, and the diaphragm. The pleural cavity is bounded by a double-layered serous membrane called pleura. The importance of thoracentesis. Thoracentesis relieve pressure on the lungs, treat symptoms such as shortness of breath and pain, and determine the cause of excess fluid in the pleural space.
Good morning, everyone. I'm Ms. Duhailong and I will be reporting about the guidelines in assisting in thoracentesis. One important guideline is to position the patient comfortably with adequate supports. If possible, place the patient upright or in one of the following positions: sitting on the edge of the bed with the feet supported and arms and head on a padded over the bed table, straddling a chair with arms and head resting on the back of the chair, or lying on the unaffected side with the bed elevated 30 degrees to 45 degrees if unable to assume a sitting position. Always remember to ascertain in advance that chest x-ray has been ordered and completed and the consent form has been signed. Assess the patient for allergy to the local anesthetic to be used and administer sedation if prescribed. Inform the patient about the nature of the procedure and the importance of remaining immobile, pressure sensations to be experienced, and that minimal discomfort is anticipated after the procedure. Always remember to support and reassure the patient during the procedure. Prepare the patient for the cold sensation of skin germicide solution and for pressure sensation from infiltration of a local anesthetic agent. Also, encourage the patient to refrain from coughing. Expose the entire chest. The site for aspiration is visualized by chest x-ray film and percussion. If fluid is in the pleural cavity, the thoracentesis site is determined by the chest x-ray, ultrasound scanning, and physical findings, with attention to the site of maximal dullness on percussion. Remember that the procedure is performed under aseptic conditions. After the skin is cleansed, the physician uses a small caliber needle to inject a local anesthetic slowly into the intercostal space. The physician advances the thoracentesis needle with the syringe attached. When the pleural space is reached, suction may be applied with the syringe. A 20 ml syringe with a three-way stopcock is attached to the needle. If a considerable quantity is removed, the needle is held in place on the chest wall with a small hemostat. After the needle is withdrawn, pressure is applied over the puncture site and a small sterile dressing is fixed in place. Advise the patient that he or she will be on bed rest and a chest x-ray will be obtained after thoracentesis. Record the total amount of fluid withdrawn from the procedure and document the nature of the fluid, its color, and its viscosity. If indicated, prepare samples of fluid for laboratory evaluation. A specimen container with formalin may be needed for a pleural biopsy. Lastly, monitor the patient at intervals for increasing respiratory rate, asymmetry in respiratory movement, faintness, vertigo, tightness in chest, uncontrollable cough, blood-tinged or frothy mucus, a rapid pulse, and signs of hypoxemia.
And now let's talk about the indications and the contraindications of thoracentesis. For the indications, first we have the pneumothorax. This is to aspirate the air that leaks into the space between the lung and the chest wall. Second, we have the hemothorax. This is to drain the blood out of the chest cavity. Third, we have the empyema. This is to remove the pus that accumulated the pleural space. Lastly, we have the bronchopleural fistula. This is to drain the fluid that has accumulated in the pleural cavity. For the contraindications, we have coagulation disorder. This is to avoid any bleeding complications. We have severe cough or hiccups. This is to avoid breathing problems, which increases the risk for underlying thoracic structures, making sedation and analgesia a frequent necessity. Lastly, we have overlying skin infection, which makes it more likely close to the possibility of introduction of microorganisms into the pleural space.
This is Catherine Chua, and I will be discussing about the complications of thoracentesis. First is the pneumothorax formation. Large case series report pneumothorax formation as being one of the most frequent iatrogenic complications, with an incidence as high as 18% in non-thoracic ultrasound-guided procedures. The accidental introduction of air into the pleural space may also result in pneumothorax formation, but can be easily prevented with a careful technique and the use of a closed aspiration drainage system. The next complication is persistent air leak. This occurs most frequently following procedures where the parietal pleura has been breached extensively, or when the volume of air leak is particularly high, and specifically outstripping the drainage capacity of any placed implantable cardioverter defibrillator. The third complication is intrapleural hemorrhage. This may be recognized through hemodynamic decompensation, drainage of newly blood-stained pleural fluid, or increasing pleural collection post-intervention. Iatrogenic intrapleural hemorrhage may be the most feared complication associated with pleural intervention, either through damage to the underlying viscera, heart, great vessels, and lung, or more commonly, the intercostal vessels. The fourth complication is re-expansion pulmonary edema. RPO is a rare but potentially life-threatening complication of pleural interventions that can develop in the re-expanding lung following drainage of effusions or pneumothoracis. Symptoms include dyspnea, cough, chest pain, hypoxemia, and post-drainage with evidence of diffuse alveolar infiltrates on chest X-ray. These usually develop within 1 to 2 hours but may be delayed for as long as 2 days.
Now let's talk about the positions and the sites for thoracentesis. For the sites, first we have the second to third intercostal space, anterior space. This is to remove the air. This is not the best choice because the incision is very visible with the potential for leaving an unsightly scar. The intercostal space is narrow in this site and it requires penetrating the pectoralis muscle. Second, we have the 7th to 9th intercostal space, posterior. This is to remove fluid or air. This is the ideal site for drainage, but many times it is not tolerated by patients with massive pleural effusions. For the positions, first we have a sitting on the edge of the bed with the feet supported with an arms on the padded over the bed table. This position facilitates access to the posterior axillary space, which is the most dependent part of the thorax. Second, we have the straddling a chair with arms and head resting on the back of the chair. This is actually indicated for those patients who are at middle age and not for older patients or for kids. Third, we have the lying on the unaffected site with the head of the bed elevated 30 to 40 degrees if unable to assume a sitting position. This is for adults if they find it tiring to be sitting in a chair.
Hello classmates, my name is Brian Miguel Martinez and I will be discussing about the difference between ultrasound and non-ultrasound guided thoracentesis. The difference between the ultrasound and non-ultrasound guided thoracentesis is that the ultrasound is indicated by the physician to a patient who has a mechanical ventilator because in a mechanical ventilator, the endotracheal tube is connected to the patient and ends in the trachea. That is why the physician must be precise in order to prevent or contact with the ventilator. Both ultrasound and non-ultrasound guided thoracentesis is indicated for small fluid collections. When you say fluid, this talks about pleural effusion. Pleural effusion is the buildup of excess fluid between the layers of the pleura outside the lungs. During this process, the lungs are squeezed in due to excess fluid. That is why removing this excess fluid returns the lung to its normal size, which gives the patient comfort. Both ultrasound and non-ultrasound guided thoracentesis are indicated for the aspiration of pleural fluid for analysis. In the name itself, this is to analyze the pleural fluid. Examples are to know what is the pH level and the gram stain and to culture it to know if there is any infection present. Pleural biopsy is indicated for both types of thoracentesis. Pleural biopsy is to diagnose lung infection or other lung disease to the patient. This is to investigate the cause of fluid collection in the lungs. Physicians sometimes prefer putting medication directly into the lungs. Examples are antibiotics. This is to treat infection that is causing pleural effusion or excessive fluid in the lungs. Uncooperative patients is contraindicated for the procedure of thoracentesis because this procedure needs the full cooperation of the patient to prevent any punctured lung and to collect all excess fluid. And also, patients who have coagulation disorder. Thoracentesis is an invasive procedure. Patients with coagulation disorder may have a risk of excess bleeding due to the inability of the blood to coagulate. The advantages of the ultrasound and non-ultrasound guided thoracentesis is that no surgical incision is needed. Only a needle is needed to use for the aspiration of fluid. Due to the use of an ultrasound, the ultrasound guided thoracentesis has a lower rate of complication. While non-ultrasound guided thoracentesis doesn't use any ultrasound, it costs less than the ultrasound guided thoracentesis. The disadvantage of the ultrasound guided thoracentesis is that it is more expensive because the patient is paying for the ultrasound, while the non-ultrasound guided thoracentesis is that it carries a higher risk of complication due to the inhabitants of using an ultrasound.
Principles of thoracentesis. First, we have microbiology. Microbiology is strictly observed during thoracentesis. The procedure is performed under aseptic conditions. The skin is cleansed and prepped before the procedure. Second is anatomy and physiology. The nurse should master anatomy and physiology for the sites of aspiration, which is the second or the third intercostal space, anterior space to remove air, and seventh to ninth intercostal space, posterior to remove fluid or air. It is also important to know how the respiratory system works in order to be familiar with the normal and abnormal findings during the procedure. Third would be body mechanics. Body mechanics is observed when the nurse positions the patient either by sitting on the edge of the bed, with the feet supported with an arms and the padded over the bed table, or straddling a chair with arms and head resting on the back of the chair. Next principle would be safety and security. The nurse must ensure safety of the patient by checking for any allergies regarding the local anesthetic used in thoracentesis. The nurse must also ensure the chest x-ray has been ordered and completed and the consent form has been signed. Next, we have the principle of sociology. The nurse should inform the patient of the expected reactions and sensations during thoracentesis. Also, full detailed information on the procedure. It is important to inform the patient that minimal discomfort is anticipated after the procedure, and cuffing should be done during the procedure. Lastly, we have the principle of physics. The principle of physics is present when pressure is applied over the puncture site after the needle is withdrawn to prevent bleeding, and a small sterile dressing is fixed in place.
For this part of the report, we will be presenting about the before, during, and after nursing responsibilities in assisting thoracentesis. These are the pre-procedure nursing responsibilities. These are the nursing responsibilities during the procedure. Lastly, these are the nursing responsibilities after performing the procedure.
Good morning, everyone. We are Group D6 and we will be reporting about lumbar tap. I am Ms. Duhay Lungsud and I will be reporting about the related terms. Lumbar tap or a lumbar puncture is carried out by inserting a needle into the lumbar subarachnoid space to withdraw cerebrospinal fluid or CSF. The tests may be performed to obtain CSF for examination, to measure and reduce CSF pressure, to determine the absence or presence of blood in the CSF, to detect spinal subarachnoid block, and to administer antibiotics intrathecally or into the spinal canal in certain cases of infection. So we mentioned the cerebrospinal fluid. So it is a fluid that is produced in the choroid plexus of the ventricles and circulates around the surface of the brain and the spinal cord. Cerebrospinal fluid is important in immune and metabolic functions in the brain. A CSF sample for testing of immunoglobulins or bacteria may be obtained through a lumbar puncture or intraventricular catheter. The choroid plexus is a secretory tissue found in each of the brain ventricles, the main function of which is to produce cerebrospinal fluid. A myelogram is a diagnostic imaging test generally done by a radiologist. It uses a contrast dye and x-rays or computed tomography to look for problems in the spinal canal. Problems can develop in the spinal cord, nerve roots, and other tissues. This test is also called myelography. Finally, we have the subarachnoid space. The subarachnoid space is the interval between the arachnoid membrane and the pia mater. It is occupied by delicate connective tissue, trabeculae, and intercommunicating channels containing cerebrospinal fluid. The cavity is small in the normal brain.
Now for the importance of lumbar puncture. So a lumbar puncture can help diagnose serious infections such as meningitis, other disorders of the central nervous system such as Guillain-Barré syndrome, and multiple sclerosis, or cancers of the brain or spinal cord. Sometimes a lumbar puncture is used to inject anesthetic medications or chemotherapy drugs into the cerebrospinal fluid.
The guidelines for assisting with a lumbar puncture. A needle is inserted into the subarachnoid space through the third and fourth, or fourth and fifth lumbar interface to withdraw spinal fluid. These are the pre-procedure guidelines for assisting with a lumbar puncture. Next, the following are the guidelines during the procedure. Lastly, these are the guidelines for assisting in lumbar puncture after performing the procedure.
So now we have the indications and the contraindications for lumbar puncture. For the indications, we have suspicion of meningitis, suspicion of subarachnoid hemorrhage, suspicion of central nervous system diseases such as Guillain-Barré syndrome and carcinomatous meningitis. For the contraindications, we have infection in the puncture site, suspicion of increased intracranial pressure, and lastly, we have hemorrhagic disorders such as a coagulation factor deficiencies like hemophilia.
Hello everyone, I am Etable Hannah Vivian and I'll be reporting about the normal findings of cerebrospinal fluid. These are the normal findings of cerebrospinal fluid. Pressure is 70 to 180 mmHg2O. Appearance is clear and colorless. CSF total protein is 15 to 60 mg or 100 ml. Gamma globulin is 3% to 12% of the total protein. CSF glucose is 50 to 80 mg or 100 ml. CSF cell count is 0 to 5 white blood cells and no red blood cells. Chloride is 110 to 125 MEq or liters. Complications of lumbar puncture. Complications of lumbar puncture are bleeding into the spinal canal or around the brain, also called as subdural hematomas, discomfort during the test, headache after the test that can last a few hours or days. If headaches last more than a few days, you might have a CSF leak. You should talk to your physician if this occurs. Next is hypersensitivity or allergic reaction to the anesthetic. Infection introduced by the needle going through the skin. Brain herniation may occur if this test is done on a person with a mass in the brain. This can result in brain damage or death. This test is not done if an exam or test reveals signs of a brain mass. Lastly, damage to the nerves in the spinal cord may occur, particularly if the person moves during the test.
For sites in lumbar puncture, the needle is usually inserted into the subarachnoid space between the third and fourth, or fourth and fifth lumbar vertebrae. Because the spinal cord divides into a sheaf of nerves at the first lumbar vertebra, insertion of the needle below the level of the third lumbar vertebra prevents puncture of the spinal cord.
Hello classmates, I will be presenting to you about the principles in lumbar puncture. In the principles of body mechanics, the nurse must assist the patient with the correct body mechanics. In this, the patient is on one side at the edge of the bed with the back exposed to the physician. The thighs and legs must be flexed as much as possible to increase the space between the spinous processes of the vertebrae. In the principles of psychology, the patient may feel insecure, loses their self-esteem, and may feel isolated. The clinician should address the needs of the patient, which will help them to participate actively and to an extent that satisfies their social needs. In safety and security, the nurse must assist the patient to maintain the position during the procedure by attending to every needs of the patient to ease the discomfort experienced by the patient. In the principles of sociology, in order for the healthcare provider to get the patient's full cooperation, he or she must explain to the patient and can communicate well in order for the patient to understand the procedure. In human anatomy and physiology, in collecting cerebrospinal fluid, as a nurse, even though we are not the ones who will be collecting the sample, it is still important to know what site will be punctured, which is the third and fourth or the fourth and fifth lumbar space. Hello again. In this topic, I will be discussing about the nursing responsibilities in lumbar puncture. So before the procedure, the nurse must determine whether written consent for the procedure has been obtained. This is for verification whether the patient has accepted the procedure. The next, explain the procedure to the patient and describe sensations that are likely during the procedure, which are sensation of cold as the site is cleansed with solution, a needle prick when the local anesthetic agent is injected. The next is to determine whether the patient has any questions or misconceptions about the procedure. This is to reassure the patient that the needle will not enter the spinal cord or cause paralysis. Instruct the patient to void before the procedure. This is to prevent any breaks from the procedure happening, since this procedure needs to be continuous. The nurse will assist the physician in cleansing the puncture site with an antiseptic agent solution and drapes the site. A specimen of CSF or cerebrospinal fluid is removed and usually collected in 3 test tubes labeled in order of collection. The tubes of CSF are sent to the laboratory immediately. This is to prevent any changes of the diagnosis. During the procedure, the patient is positioned on one side at the edge of the bed or examining table, with the back toward the physician. The thighs and legs are flexed as much as possible to increase the space between the spinous processes of the vertebrae for easier entry into the subarachnoid space. A small pillow may be placed under the patient's head to maintain the spine in a horizontal position. A pillow may be placed between the legs to prevent the upper leg from rolling forward. Next, the nurse assists the patient to maintain the position to avoid sudden movement, which can produce a traumatic bloody tap. The next, the patient is encouraged to relax and is instructed to breathe normally because hyperventilation may lower an elevated pressure. After the procedure, instruct the patient to lie prone for 2 hours and then flat in the sideline position for 2 to 3 hours and then in the prone or supine position for 6 hours. This is to separate the alignment of the dural and arachnoid needle punctures in the meninges to reduce the leakage of CSF. And then, monitor the patient for complications of lumbar puncture. Notify physician if complications occur. And then encourage increased fluid intake to reduce the risk of post-procedure headache.